Welcome to episode 21 of the Pro PA podcast. I'm your host, Prof G, and today we're kicking off our pulmonary circulation series with a combined clinical medicine brief on two closely related topics, cor pulmonale and pulmonary hypertension. In this episode, we'll cover the basics, causes, risk factors, clinical presentation, workup, and management of these two conditions. And as always, we'll end with vignette-style questions to reinforce what you've learned. Let's dive in. First, let's look at the kinder patho. What are cor pulmonale and pulmonary hypertension? So let's start off with pulmonary hypertension. Pulmonary hypertension is an elevated pressure in the pulmonary arteries, and this is defined as a mean pulmonary artery pressure, or MPAP, greater than or equal to 20 millimeters of mercury at rest. So anything less than 20 millimeters of mercury is considered normal, and this is confirmed by a right heart catheterization. Now, in the past, and still in a lot of textbooks right now or review books that you'll look at, the MPAP is generally looked at as greater than 25 millimeters of mercury for pulmonary hypertension at rest and greater than 30 millimeters of mercury with exercise. But be aware that this pressure has changed in the textbook that I reference, which is current, and they are suggesting that anything greater than 20 millimeters of mercury is considered pulmonary hypertension. Now, cor pulmonale, on the other hand, is considered to be right ventricular dysfunction or failure secondary to chronic pulmonary hypertension, usually caused by lung disease or hypoxia. So, as you might note here, pulmonary hypertension can lead to cor pulmonale if the pulmonary hypertension is caused by lung disease. So, pulmonary hypertension is often the underlying cause of cor pulmonale. Think of it as a right-sided heart failure caused by lung disease. And when I like to think of the kinder patho of pulmonary hypertension, especially in the setting of lung disease, I think of it as the lungs are pretty smart. There's lots of little capillary beds surrounding the airways, and whenever there's an area or a section of lung that is not working properly, the body tends to decide, you know what, I'm not going to send any blood to that area. I'm going to go ahead and send it to an area that is getting better oxygenation. And so it kind of clamps down those arteries and arterioles in that area and shunts the blood to other parts of the lung. But when you have someone with pretty advanced lung disease where all of the lung is damaged, then you have these clamp downs of hypertension all over the lung trying to find a good piece of lung to send blood to. As you can see, that would increase the general pressure within the arteries of the entire lungs. And this is what is pulmonary hypertension caused by lung disease. And over time, because of that high pressure, that right side of the heart, which is pumping the blood towards the lungs, is having to pump against that high pressure. And so over time, that right side of the heart can begin to fail. And that is what's called cor pulmonale. So, who gets cor pulmonale and pulmonary hypertension? Well, as far as pulmonary hypertension, there are 5 WHO classification groups, and this is based on the underlying cause. I do think you need to be familiar with these groups, so let's go through them. Group 1 is the pulmonary artery hypertension, or PAH, which is the not pulmonary hypertension, this is pulmonary arterial hypertension, which is an idiopathic, hereditary, or drug toxin induced form of arterial hypertension. It is rare, but is severe, and it is its own group, group 1. Group 2 is going to be pulmonary hypertension due to left heart disease. So this is the most common type. It is caused by left-sided heart failure, which backs the blood up into the lungs, causing increased pulmonary hypertension and valvular disease. Group 3 are going to be the group that we looked at most in the pulmonary module. So this is going to be pulmonary hypertension due to lung disease or hypoxia. And this includes COPD, interstitial lung disease, obstructive sleep apnea, and essentially anything else that affects the lungs, which then in turn affects the pulmonary arteries. Group 4 is going to be the chronic thromboembolic pulmonary hypertension, and this is caused by unresolved pulmonary emboli. So essentially, pulmonary emboli are forming little plugs in the pulmonary arteries, the small vessels of the lungs, and this is increasing the pressure of the lungs. Group 5 is going to be our grab bag, our miscellaneous category, and these are going to be filled by rare causes like sarcoidosis or hematologic disorders. Anything that doesn't fall into the other groups can fall into group 5. Now, as far as cor pulmonale, who gets cor pulmonale? Well, it's most often seen in that group 3 pulmonary hypertension. So these are the lung disease related. And common causes include COPD, which is the most frequent cause. You can also have chronic hypoxemia from interstitial lung disease or sleep apnea. And pulmonary vascular disease is also considered a risk factor for getting cor pulmonale. So, how do these patients present? Well, pulmonary hypertension, the symptoms are typically dyspnea on exertion, which is the most common symptom that we see. They can get fatigue, chest pain, lightheadedness, and then also signs of right heart failure in more advanced stages like peripheral edema, ascites, and things like that. So, physical exam findings, we might expect to hear a loud P2 or accentuated second heart sound in the pulmonary valve area. We also might again see those signs of right-sided heart failure, JVD, hepatomegaly, or peripheral edema. For cor pulmonale, symptoms are going to be pretty similar: dyspnea, fatigue, peripheral edema, weight gain from fluid retention. They can even get syncope in really severe cases, and physical exam findings are going to be pretty much the same: increased JVD, right ventricular heave, maybe a palpable impulse at the lower left sternal border, and hepatojugular reflux. So, how do we work up these patients? Well, the initial labs and testing that we do, well, we want to get a BNP. This is going to let us know whether this cor pulmonale is due to the right heart strain or whether it is going to be related to other heart failure. And ABG can also show us how hypoxemic the patient is or hypercapnic. Imaging, chest x-ray, we can see some enlarged pulmonary arteries or right-sided heart enlargement. An echocardiogram is essentially considered first line for assessing for right heart function and estimating pulmonary artery pressures. The definitive diagnosis, however, for pulmonary hypertension is going to be a right heart catheterization. And this is going to confirm those levels of pulmonary hypertension that we mentioned initially, which we would measure that pulmonary artery pressure, and we're looking for a pressure greater than or equal to 20 millimeters of mercury at rest. Other evaluations we would want to do are evaluations to look at underlying lung disease like pulmonary function testing. We could do sleep studies if we're suspecting sleep apnea, or a VQ scan to evaluate for chronic thromboembolic disease. So, how do we manage it? Well, pulmonary hypertension, the mainstay of treatment is to treat the underlying cause, and this is based on that WHO classification. So, group 1, the PAH patients, we're going to start with vasodilators, and there's several other medications that we can give to help vasodilate and help relieve some of that pressure. For group 2, we're going to manage the left-sided heart disease with those medications. For group 3, we're going to optimize lung disease treatment, including bronchodilators for COPD, oxygen for hypoxemia, etc. Group 4, we're going to consider anticoagulation, possible pulmonary thromboanorectomy if necessary. And oxygen therapy has been shown to reduce mortality in the group 3 of pulmonary hypertension. For cor pulmonale, we're going to treat the underlying pulmonary disease. So if they have COPD, we're going to treat their COPD. If they have interstitial lung disease, we're going to try to treat that. And in some cases, when they have a lot of fluid overload, we can give diuretics. This helps with some of the symptom relief of peripheral edema, but give it cautiously because you want to avoid reducing preload excessively. We also want to consider that long-term oxygen therapy, which is indicated in our hypoxic patients. So, quick clinical pearls. 1. Pulmonary hypertension is classified into the 5 WHO groups. Always treat the underlying cause for the best outcome. Number 2, a loud P2 on exam is hallmark of pulmonary hypertension. 3, right heart failure symptoms like JVD, peripheral edema are all clues to potential cor pulmonale in patients with chronic lung disease. And number 4, in cor pulmonale, managing chronic hypoxemia with oxygen therapy is key to reducing right heart strain. All right, now that we've gotten a crash course through cor pulmonale and pulmonary hypertension, let's do a quick knowledge check. So question 1, we have a 65-year-old man with a history of COPD who presents with worsening dyspnea, peripheral edema, and JVD. Physical exam reveals a loud P2 and hepatomegaly. Echocardiogram shows right ventricular hypertrophy and pulmonary hypertension. What is the most likely diagnosis? Is it A, congestive heart failure, B, cor pulmonale, C, pulmonary embolism, or D, pulmonary arterial hypertension? I'll give you a few seconds. So if you said B, cor pulmonale, you are correct. This patient has chronic hypoxemia from COPD, which has caused pulmonary hypertension, which has led to that cor pulmonale, which is that right-sided heart failure. Now, question 2, we have a 50-year-old female who presents with progressive dyspnea and lightheadedness. Physical exam reveals a loud P2 and JVD. Right heart catheterization shows an MPAP of 28 millimeters of mercury at rest. Which WHO classification is most likely if she has no history of lung disease or left-sided heart failure? Is it group 1, the pulmonary arterial hypertension category, B, group 2, pulmonary hypertension due to left heart disease, C, group 3, pulmonary hypertension due to lung disease, or D, group 4, chronic thromboembolic pulmonary hypertension? I'll give you a few seconds. So if you said A, group 1, you are correct. The absence of left heart or lung disease makes this a candidate for idiopathic pulmonary arterial hypertension, which falls into that group 1 category and is the most likely cause. All right, we want to thank you for tuning into this episode of the Pro PA podcast. I hope this episode gave you a better understanding of the two interrelated conditions, their clinical presentations, workup, and management. And remember, if you want to take a deeper dive into these pulmonary topics, be sure to check out my pulmonary playlist on my YouTube channel, Prof GPAC, for more information on these types of topics. And stay tuned for my next episode in our pulmonary circulation series, where we'll tackle pulmonary embolism, which is one of the most high-yield topics for panceprep and clinical practice. If you found this episode helpful, please follow the podcast and hit the notification bell to stay updated. And remember, this is the Pro PA podcast, where future pros in medicine are made. I'll see you soon.